from prostate cancer treatment. So today we're going to be discussing a little bit of anatomy, just to get us familiarized with the location of the prostate in relation to other structures. And the reason to do that is to make sure everybody understands why there are some side effects based on the location of the prostate, and so I can explain what the different treatment options are. We also are going to briefly touch on some statistics and how we diagnose prostate cancer, and then we're going to talk about treatment options, and we're going to focus a little bit more on radiation oncology treatments, so treatment with radiation therapy, and the utilization of certain devices, such as a hydrogel that we are utilizing SpaceOART to reduce the possibility of inflammation or irritation of the rectum, which could lead into certain side effects. So this is a side view of the body, and we can see that the bladder is here on top of the prostate. The bladder drains into the urethra, which comes out into the penis, and just directly behind it is the rectum. So as you can see, the prostate is intimately related to the bladder and the rectum, and no matter what treatment option you choose, there's going to be implications to the bladder, the rectum, and it needs to be taken into consideration regardless of the treatment option you choose. We know that approximately 1 man out of 9 will be diagnosed with prostate cancer during their lifetime, and it's the second leading cause of cancer in American men, just behind lung cancer. So it's important to talk about this. As of 2018, there were approximately 165,000 cases every year, but unfortunately, there were approximately 30,000 deaths each year. So that's a very high number of deaths, and it is extremely important that we diagnose prostate cancer at an early stage so it can be treated more effectively. Because when prostate cancer is localized, meaning that it's still in the prostate, there is a very high chance of cure. However, once it has spread to the lymph nodes or bone or other organs, the chance of cure is significantly less. So we wanna try to catch this at an early stage, in order to be able to give the patients the best possible chance for a cure. So how do we diagnose prostate cancer? So the most important way is screening. So, and we hear about screening in different types of cancer. For example, skin cancer, we recommend people to go to the dermatologist every year, get checked. Breast cancer, women have mammograms, every year. Make sure that there's nothing showing up on the breast, and making sure that you can compare it to the previous year. So the same is for us men. It is recommended that approximately at the age of 50, you start getting screened for prostate cancer. Now, if you are African American, you probably want to start getting checked at a little bit earlier age, or if you have a strong family history as well. So you may want to consider doing that in your late 40s. So the two best ways for screening are, and I guess they're not different ways, but they're complementary to each other, would be, number one, doing a blood test, which is called the PSA, or prostate specific antigen. And that's going to give us a measurement of that specific marker in the blood. And normally it's between 0 to 4. And we want to make sure that it stays in that range. Now, if it starts going up, for example, if it's 3.5 this year, but next year it's 3.7, and the following year is 3.9, even though it's still in the normal range, we want to start keeping an eye on it, because we probably want to start considering doing some workup to see if this patient is developing prostate cancer. So it's, of course, if it's greater than 4, at the beginning, then we're going to be really concerned and going to proceed with a biopsy. The other complement to the PSAs is doing a digital rectal exam. So during your yearly visit to your physician, there's a high likelihood that they're going to, in addition to doing the blood test, they're also going to do a rectal exam and feel the surface of the prostate. And if they feel any abnormalities, any hardness of the prostate or lumps or any bumps that are not supposed to be there, that would also alert us that there is something that needs to be evaluated. Now, what do we do if somebody has not been is not being screened, but they just start having symptoms? So, for example, sometimes developing urinary symptoms such as an infection, bleeding. Sometimes people notice that they have blood in the sperm. That could also be an indication that there's something wrong going on, and they need to be checked for prostate cancer. Same as for blood in the urine, you need to be checked for bladder conditions, kidney conditions, but also could be an indication that there's something wrong with the prostate. So the only way to confirm, once we have the suspicion, either from screening tests or from somebody that's having symptoms, we would proceed with a prostate biopsy. So a biopsy is putting a needle inside the prostate and trying to get a small sample of it so that it can be sent to the lab and be analyzed. So that would be the best way of determining if somebody has prostate cancer. So there's two ways of performing the prostate biopsy, and it's not the most comfortable, but it is the best way to do it. So for many years, the transrectal approach, the one on the right side, was the most common. So the man would be lying on his back on the exam table. There would be an ultrasound put in the rectum, and there will be a needle put through that ultrasound and go through the rectal wall into the prostate and get a biopsy. So the downside with that is that you're putting a needle through the rectum where there's a lot of bacteria, and even if you put people on antibiotics, there's a higher risk of complications and more issues. So there's been a trend in the last few years to transition to what's called a transperineal approach. So it's very similar. It is you still have to have an ultrasound put in your rectum, but there's not going to be any needles coming through the wall of the rectum, but rather through the skin that's in between the testicles and the anus. That skin will be anesthetized and it will be cleaned, and then we put a needle through that area and get a sample from the prostate gland. So that's the preferred approach now, is the transperineal approach, but there's still many places where they're still doing the transrectal approach. But that's how, in general, the biopsies are obtained. So once the biopsy sample has been obtained, we send it to the lab, and it will be analyzed by a pathologist who's going to look at it on the microscope. And what they're going to tell us is something called the Gleason score. So the Gleason score is a measurement of how aggressive the cells in the prostate are. So they're going to look at certain characteristics of the cancer cells in the prostate, and they're going to tell us what type of Gleason or what number is the Gleason score. So the Gleason score goes from 1 to 5, and they're going to give us the primary Gleason, which is how the majority of the cells look like. And then they're going to give us a secondary Gleason, which is what the rest of the cancer cells look like. So, for example, if they give us a Gleason score of 6 or below, that is a low risk, meaning that these cells are growing slowly and they're unlikely to cause any problems, even though it's a cancer. Gleason 7 is an intermediate risk, and Gleason 8 or above is a high risk cancer that has high propensity for it to be spreading to the lymph nodes or to the bone or to other organs. So we're gonna get that Gleason score. We're gonna get all of the X-rays, and are gonna show us if the cancer has spread to the lymph nodes or not. And we're gonna get the level of the PSA. And with all of that information, we're gonna put you in a risk category. So you're gonna either be put on a low risk, intermediate risk, or high risk category. And based on that, then we're going to discuss how to treat you. Other factors that are taken into consideration could be the PSA velocity, which means how quickly the PSA is going up. For example, if we have somebody that this year, or let's say, for example, in 2021, they had a PSA of 3.5, but in 2022, the PSA is 7, means that the PSA doubled in 1 year. So that's a very high PSA velocity, because the PSA is going up extremely quickly. Now, if PSA goes up from 21 to 2022, from 3.5 to 3.6, it is a very slow PSA velocity. There are certain other genetic tests that can be done that help us determine how aggressive the cancer is and if the person would benefit from certain other treatment options, and they're used more and more frequently these days. How much tumor there is in the prostate, for example, if it's just in a small area, versus if all of the samples of the prostate come back positive with cancer. Of course, that's more concerning because there's more amount of cancer in the prostate, and other factors that we would take into consideration, such as race or other factors. So once we have made a diagnosis of prostate cancer, it is extremely important that the patient had the opportunity to discuss with his physicians what are the options of treatment. We recommend a multidisciplinary approach. So that means that prostate cancer is not a cancer that can be the treatment options cannot be only discussed by one specialty. So it would be detrimental to the patient if they only meet with me, the radiation oncologist, and I would only talk to you about radiation treatments, which I never do. I talk to patients about all the options because I want them to make sure that they choose all from whatever is the best option for them. So it's recommended that they meet with a urologist, and they meet with a radiation oncologist, they meet with their primary care physician, and any other specialty that may need to be involved so they can consider their different options. So we need to determine what we need to look at the patient as a person and determine what the patient's wishes are, what the patient condition is, and then we can make decisions. So for example, if we have a very healthy, very active 65-year-old that, it's exercising in the gym every day, doesn't take any blood pressure medications, has no diabetes, has some arthritis, but nothing major, and is going to likely live another 20 years, that person would be somebody that needs to definitely choose some form of treatment because they're going to be alive for many more years and they're in good health. And they could choose to do surgery, they could choose to do radiation, or they could choose not to do anything. But they need to be advised that they need to be watching this cancer. On the flip side, if I had a 65-year-old that was very unhealthy with bad diabetes, bad heart problems, and is only going to live 6 months, perhaps that person shouldn't have any treatment at all, because we know that they're going to die from their heart disease, just 6 months down the line. So it probably would not be appropriate for us to discuss any treatment options for a prostate cancer. If sometimes we have 80-year-olds that are extremely healthy and active, nowadays, that people are living longer and healthier lives. And it's not unusual for us to have people in their late 70s or 80s that are extremely active and want to have treatment. So at that point, they would discuss with their urologist, with the radiation oncologist, with their primary care physician, what is the best option for treatment. So when we talk about side effects and risks, of course, let's remember the anatomy that we were talking about. So we're going to be talking about the rectum, the bladder, and of course, sexual side effects. So all of those need to be taken into consideration. So surgery is an excellent treatment. It has been around for many, many decades. And nowadays, the surgeons are able to do very, very what's called minimally invasive approach with the assistance of a robot, in which they can remove the prostate without doing a big operation. And there's less time in the hospital and less risk for bleeding, less risk for infections. I mean, it's still an invasive procedure. You're still going to have to be in the hospital for a day or two. May still need to have a catheter in the bladder, but it's an excellent, excellent treatment technique. The other option would be some form of radiation treatment. 3D conformal is no longer used for treatment of prostate cancer, so we just put that there for historical perspective, but that's no longer recommended and no longer used. Nowadays, we use more intensity modulated radiation therapy, or shorter schedules, which use very focused, precise form of radiation called stereotactic radiosurgery. And we also use another form of external radiation, which is different type of radiation. It's called protons. That has not been proven to be more effective than IMRT or SBRT in the treatment of prostate cancer. It's very expensive and only available in a few centers in the country. But it's excellent for other types of tumors, for example, brain tumors, certain children, that have tumors in areas that have had radiation before. Protons are extremely, extremely good option. And, there's some men with prostate cancer that choose to go that route, but the other ones are just as good. And then we have what's called brachytherapy, which is the placement of seeds inside the prostate, which also a very effective form of treatment. It's an invasive procedure, so there's a little bit more side effects immediately after the procedure, but it's an excellent way of treating prostate cancer as well. And last but not least could be active surveillance. So for example, if we have somebody that has a very slow growing prostate cancer, and that the likelihood is that it's not going to spread, it's only in a very small amount of the biopsy in just one part of the prostate, we can just watch them and not do anything. So that is a very good alternative in people, but it needs to be, there's got to be a physician watching and making sure that everything is working well. So we're going to talk a little bit more specifically about radiation, which is my specialty. But again, I typically discuss with patients all of the treatment options, and we make sure that we discuss surgery or surveillance as an alternative. Just because I do radiation doesn't mean that everybody has to have radiation. This is a very, very patient-specific decision. We, the doctors, cannot make the decision for the patient. We can certainly help and guide. And as I tell my patients, I want the best for you. So whatever treatment option you decide is the best for you, I'll be supportive of that. But if they decide to proceed with radiation, then we talk about that. So radiation, it's and we're going to talk about external radiation, which is delivered by a machine first, and that is use high energy X-rays. And those high energy X-rays damage the cancer cell. So what happens is that the cancer cell is not very smart and doesn't know how to fix the damage, and eventually dies, and that's how radiation becomes effective. It kills cancer cells. Radiation also can damage normal cells in the bladder or the rectum. However, the normal cells of the bladder or the rectum, they're smart, and they know how to fix that damage. So that's how side effects happen, but then the body recovers and the side effects eventually go away. Yes, there's some small possibility of certain side effects being permanent, but nowadays with the technology we have, it is very, very safe and effective. So the most common issues are associated with fatigue, irritation of the rectum that could show up as diarrhea, tenderness, some hemorrhoid type of sensation. There could be some urinary problems such as burning sensation when you urinate. There could also be frequency, so urinating more often, or urgency, which means when you need to go, you really need to go. There could also be some sexual side effects from radiation. There's a possibility of impotence, which is similar to surgery. Even with the robotic surgery, there's still a chance for impotence, and there's still a chance for leakage of urine with surgery. With radiation, the chance of leakage of urine is minimal. So the types of radiation, again, we can use external beam radiation or internal radiation. External beam, so IMRT or stereotactic radiation are the most commonly available methods of treatment. We are tending to use more shorter courses of radiation nowadays. So stereotactic radiation is very popular, and we are utilizing it more and more. I have the opportunity to treat several patients with this modality, and works extremely well if done correctly. And then brachytherapy, you can have the seeds placed in the prostate. That's called low dose rate implants. Or you can have some catheters inserted in the prostate and connected to a radiation machine and delivered over a few minutes, and that's called high dose rate implant. So this is a similar anatomy view that I was showing at the beginning, but it's a little bit more, technical, so that you can see more of what our dilemma is when we're treating prostate cancer. So on the right, we have a side view similar to the one I had shown you before. You can see the tailbone right here in the back, the bladders here in the front, the rectums here in the back, and this area in red is the prostate. So it's very difficult for us to, or in the past, it was very difficult for us using, older radiation techniques to reduce amount of radiation to the bladder and the rectum. So we had to treat people for many, many weeks. So giving them low doses of radiation every day for up to 9 weeks in order to be gentle on the rectum and the prostate. So it's a very effective treatment. You can do it over 9 weeks, but it's extremely inconvenient for somebody to have to come back and forth to the radiation treatment center for 9 weeks. But it is a very good option. This is what's called an axial view. So this is like we cut you in slices, and you see the right hip over here, you see the left hip, and you'll see the prostate here, right here in the middle, and you see how close it is to the rectum, which is just behind it. So here are some graphs of what happens with rectal toxicity. So you can see that, so with the use of spacer, so by creating an artificial space in between the prostate and the rectum, you can reduce the risk of urinary or gastrointestinal toxicities here and urinary toxicity. So it does significantly reduce the chance And let me explain how that works. So when we're utilizing radiation for the treatment of prostate cancer, here's the prostate again, here's the bladder, and here's the rectum. So we know that they're close. We know that the prostate moves because if there's gas or stool in the rectum, the rectum moves and results in movement of the prostate. So it's like hitting a moving target every day. So we have to be very careful every day doing special x-rays so that we can make sure that we know where the prostate is located. So in order to reduce that potential for inflammation and irritation of the rectum, they designed this gel that you inject, similar to the biopsy, through the skin in the bottom. We inject that gel into this area and creates an artificial space, therefore allowing me to minimize radiation dose to the rectum. So this is another view, like we cut the patient in slice. So we see the prostate, we see the red is the radiation dose. So we have to give a little bit of safety margin around the prostate because, as you can imagine, the patient is alive. The patient is breathing. There could be gas that passes through the rectum and the bladder is filling as we're doing the treatment. So we want to make sure that there's a little bit of a safety margin. So there's going to be a little bit of extra dose outside of the prostate, but that could get very close to the rectum. So that's where any extra radiation dose to the rectal wall can cause diarrhea or inflammation, and it could even show up as bleeding several years after radiation is completed. It's rare, especially when with the technologies we have, but if you're not careful, you can create a lot of issues in the rectum. So the benefits of putting a hydrogel is that you're going to create this space that you didn't have before, and you can see that the radiation dose is going to stay in the prostate and is going to barely touch the rectal wall. So it significantly reduces exposure of the anterior rectal wall, and by doing that, we reduce the potential for side effects. It stays in place for about 3 to 6 months, and then the body reabsorbs it and eliminates it. So it is just a temporary space that is created so that it can be utilized during the radiation treatment time. Let me go back to that for a second. And it's inserted via a brief outpatient procedure. We just do local anesthesia. It's a little bit uncomfortable, but it's brief, and the patients tolerate it really well. So it is a synthetic biodegradable material, which is not toxic, and it's dissolved in about 6 months. And it has been shown that there's 8 times benefit. So there's decline in bowel or urinary or sexual quality of life when compared to SpaceOART Hydrogel patients. So there's a significant improvement in bowel toxicity with this gel. So it is a significant improvement in quality of life. If we're reducing the possibility of side effects, we're definitely going to be improving the patient's quality of life, which is ultimately what we want. We want them to be cured of the cancer, but we also want them to have good quality of life, because it doesn't do me any good to treat a patient, or if they have surgery and they end up having leakage of urine and have to wear a pad for the rest of their life, and that limits their ability to be outdoors or to exercise or to be intimate with a partner, that's not quality of life. If on the other side I do radiation and I damage the rectum and the patient's having bleeding in the rectum and is having pain and other problems, that's not good quality of life either. So we need to make sure that any treatment option that we choose is going to result in the best quality of life for the patient, and that the patient is going to be treated with whatever they prefer. For example, I have patients that I talk to about radiation, and they say, doctor, I appreciate you talking about radiation, but I just want to have it cut out and get it over with. I think, and I say that's a perfectly reasonable option, and and they have their surgery and have good success. Other people that say, I don't like needles, I don't want a knife near my prostate. I wanna have radiation done because I want something that's non-invasive. So it's a very patient-specific decision. Nobody can make that decision for you. But the good news is that you're not going to make a wrong decision. And the reason you're not going to make a wrong decision with treatment is because either surgery or radiation are equally effective. So what does that mean? It means that the chance of being cured of prostate cancer with radiation or with surgery, it is exactly the same. Sometimes patients ask me, well, but what gives you the highest chance that it's going to come back, or the lowest chance that it's going to come back? And the answer is the same. So since they cure you the same, means that either with surgery or radiation, is going to be the same chance of the cancer coming back. So that helps people understand that both options are good and they're not going to make a mistake. So the hydrogel has been evaluated in many places. I think over 50,000 patients are treated worldwide, and I think that's even higher than that nowadays. Personally here, we have been using it in quite a bit of patients, and we are finding that patients are much more interested in having the gel placed because they've heard from other people, talked to friends, or read it online. There's so many online or Facebook forums, and people are talking about this new procedure. So people are really interested in getting this done. So we're seeing a lot of interest, and that's why we wanted to share that with everybody that's considering having treatment. So I think we have a video. I'm going to try to play it here. Hopefully it'll work.
I was diagnosed with prostate cancer. The level of cancer required medical intervention.
When you're trying to radiate the prostate with radiotherapy, you always have to add in a margin. With SpaceOART, it allows us to treat the prostate without compromising at that border between the prostate and the rectum, because that border isn't there anymore. There's a big space.
By increasing that physical space and decreasing that radiation dose, it really preserves a man's quality of life.
Having a space there between the prostate and the rectum reduces a lot of that worry.
The SpaceOART treatment is not a process or procedure that needs to be feared in any way.
I strongly encourage all of my patients who are having radiation to have a spacer replaced before treatment.
My greatest hope that it would be available to all persons everywhere.
Okay, so there's also some online resources for SpaceOAR.com, and it is a good alternative and a good treatment option for the treatment of prostate cancer. I think that at this point, I don't know if we want to open it up for questions.